All right, so I am Daniel Sessions. I'm one of the toxicologists here at Emergency Care Consultants Addiction and Toxicology in Minneapolis, Minnesota. I have this lecture today. It's called Toxic Alcohols, and we'll see why maybe that's a little bit of a misnomer in a second. Some of these slides, especially some of the analytical chemistry stuff, I built this off of a more lab-based lecture that Dr. Palmer gave to me when I was a fellow, and I'm reusing some of those slides with his permission. And then I also have some dialysis instructions for methanol that are adapted from a protocol that the Minnesota Poison Control Center uses that was built by Ben Orozco. So I've included those two guys for helping me out with this. So the term toxic alcohol is a bit of a misnomer in that all alcohols are toxic. All use of even ethanol is hazardous use and has health effects, deleterious health effects. Ethanol and isopropanol can exhibit toxicity via their alcohol moiety. Ethylene glycol, methanol, diethylene glycol make toxic metabolites in the forms of organic acid, and that's what mediates the toxicity. And for those three alcohols, those are the main ones we're going to talk today, and they're really more appropriately called alcohols with toxic metabolites. The way we're going to go through this is the etiology of various toxic alcohol poisonings in terms of numbers per year. We'll talk about relevant chemistry. We'll talk about the clinical presentation after ingestion or exposure. We'll talk about the appropriate way to go about diagnosing an exposure to include lab analysis. And then we'll talk about how we manage these patients clinically in terms of antidotes and enhanced elimination, and even some supportive care and adjunctive treatments. What I will throw in here, and if you're a toxicology fellow, you know this, a lot of the calls that you're going to receive for a supposed toxic alcohol are actually going to be alcoholic ketoacidosis, right? We know that people that engage in chronic ethanol misuse and abuse here in Minnesota, we call them chronic inebriates. They have a flipping of their NAD and NADH ratio, right? And we've seen these patients present. The classic presentation for alcoholic ketoacidosis is a period of abstinence from alcohol use, and then they can present to the emergency department, aka, or more likely, a period of abstinence followed by recrudescence of alcohol use, misuse, and abuse. And this slide is just kind of demonstrating the chemistry behind that flipping of the NAD/NADH ratio and the formation of those ketone bodies that will give us an elevated osmolar gap as well as an anion gap acidosis in the setting of potentially low or negative ethanol level. And that obviously for an emergency physician, internal medicine physician, critical care physician, any of those people, that could be confused for ingestion and acidosis from a toxic alcohol. But it's our job to be the subject matter expert and to be able to delineate between the two. So that's why I've included this slide, and it's a good slide to refer back to whenever you're studying for the boards or treating one of these at the bedside. And I just pulled this slide from Goldfrank's. So in the 2017 NPDES report, there were almost 12,000 isopropanol exposures, almost 7,000 ethylene glycol exposures, and almost 2,000 methanol exposures, as well as 922 diethylene glycol exposures reported to poison control. I have an asterisk by that diethylene glycol exposure because it looks like the code that they use and the way they describe the substance, all brake fluid exposures, which may or may not have diethylene glycol to a significant degree, fall under that. And so that's why that number looks so high. In that same NPDES report, we saw 2,000 cases treated with fomepizole, right? The antidote, or what we think of as the antidote for ethylene glycol and methanol exposure, as well as 44 uses of ethanol for treatment for toxic alcohol, which is what we think of the more old school alcohol, toxic alcohol treatment. So the basic chemistry here, right, in alcohol, we see that hydroxyl group, we see the ether structure there, we see the aldehydes that are formed in that first step of alcohol metabolism, and then that organic acid that's formed in the second step. And we really think of those organic acids as the true toxic metabolite of these toxic alcohols. We have primary, tertiary, and secondary alcohols. And the general alcohol oxidation step, like I said 2 slides ago, right, we see that oxidation to an aldehyde followed by that oxidation to a carboxylic acid. This occurs with the primary alcohol, which is what these toxic alcohols we're going to be talking about are, for the most part, secondary alcohols. So now this is isopropyl, right? It's metabolized to a ketone. We don't undergo further oxidation and formation of that toxic organic acid. And then tertiary alcohols, we don't really see any reaction. You're probably not going to see a lot of tertiary alcohol exposures, except in maybe a moonshine or some of those fusel alcohols that come out at the end of a moonshine column. We'll have those and will cause basically intoxication, but not the formation of those organic acids like we would see with our typical toxic alcohols. So the first pearl I'd like to throw out there is just that toxicity occurs by an accumulation of metabolites, and in this case, those metabolites are the organic acids for ethylene glycol and methanol. So this is the structure of ethylene glycol. You're very lucky if you get that as one of your board questions because it's a pretty easy structure. In terms of the chemical itself, sweet taste, no odor, it's colorless. We see it formulated with that fluorescein dye, just like the dye we put in people's eyes in the emergency department. And that's so that when you're using it as an antifreeze, right, you can detect those leaks. We see it as a de-icing. Now more planes at airports are de-iced with propylene glycol than ethylene glycol, but it's still in use as a de-icer. It's an engine coolant. You will see it in hydraulic brake fluid, and then in water-based latex. Common exposure you're going to see for this is an intentional antifreeze ingestion. Antifreeze is up to 95% ethylene glycol. There are antifreezes that are methanol containing and other substance containing. You should be aware that I recently had a case that was a large volume antifreeze ingestion, found the jug of antifreeze, and the person had a methanol level of greater than 200. So it can be an attempted inebriation, in other words, as an ethanol substitute, because it is intoxicating. Homicidal attempt, there's well-documented cases in the lay press of partner on partner, homicidal intent by poisoning with ethylene glycol, particularly because of this sweet taste. It makes it easier to mix into things like coffee and tea. And then accidental exposures, the classic one being ethylene glycol placed into a non-standard container, maybe an old Gatorade bottle or something like that. And then you can have, especially in pediatrics, that lick, sip, taste ingestion because of that sweet flavor. You'll see a lethal dose quoted as 1.5 milliliters per kilogram, but like most things, that survival has occurred at higher doses and death has occurred at much lower doses. This dose, like many things, comes from either infusing the peritoneum of a rat with this or giving rat large oral doses of this. So I would take that lethal dose report as a grain of salt, but be aware of the number because it may pop up in your reading. The parent compound, ethylene glycol itself, is going to cause intoxication. It's the metabolites that are responsible for the toxicity that we really care about and that we really want to prevent. The glycolic acid that's formed is largely responsible for the NI-GAP metabolic acidosis and the renal injury. And then oxalic acid also is renal injury, particularly the formation of crystals with calcium. Acidosis promotes the formation of those crystals, or at least the precipitation of those crystals as well. This is a chart of ethylene glycol metabolism. If you're listening to this and you're not a toxicology fellow, you probably don't need to know a whole lot of this. I think this chart has some important therapeutic implications. In other words, you can see that that ADH, that slow metabolism, is probably our best target for therapy because it's the rate limiting step. Once you're forming that glycoaldehyde, that intermediate metabolite that's probably not present in the blood for that long, the further steps down that pathway are a little more rapid. So that's why alcohol dehydrogenase is our therapeutic target here, because that glycoaldehyde is present so temporarily. And you can see the formation of glycolic acid, formation of glyoxylic acid, and that subsequent formation of oxalic acid. And the other thing that this pathway demonstrates is the reason why we give things like thymine, pyridoxine, and magnesium, and the idea being that we're going to help form these less toxic metabolites, drive that metabolism towards those less toxic metabolites. But the administration of thymine and pyridoxine and magnesium are definitely adjunctive treatments. This is just a visualization of what that calcium oxalate crystal looks like. In case you see the image on the board, that the right-sided image is a renal biopsy showing the formation of those crystals. But this image up here, you can see how similar that structure is to the parent compound ethylene glycol with the calcium adjacent to it. So these phases of ethylene glycol toxicity, especially how people are going to present to you in real life, you should be aware of these progression of symptoms, but realize that there's some overlap and none of these phases are necessarily mutually exclusive. Phase 1 is that early neurologic phase, beginning with intoxication and inebriation, progressing forward, just like you may see with even an ethanol ingestion, right? Vomiting, nystagmus, coma, seizure, hyperreflexia are all things that can occur with large ingestions of ethanol as well. In pediatrics, we seem to see more hypoglycemia. The second phase is more of a cardiovascular phase. Again, you can see this even with ethanol, especially the tachycardia and mild hypertension. The compensatory hyperventilation, right, is probably respiratory compensation for that metabolic acidosis. And patients can also develop pulmonary edema in this stage. Phase 3 is the renal phase of toxicity. So the development of flank pain secondary to those oxalic acid crystals forming, oliguria, acute tubular necrosis, hematuria, proteinuria, all those things being a consequence of that toxic organic acid as the glycolic acid, as well as the formation of those crystals. And just to reiterate, you can see that pearl down there. That phase onset of progression is unpredictable and definitely multifactorial, right? A lot of your toxic alcohol ingestions are going to be in chronic alcoholics, and that does have some implication for their metabolism and treatment. And we'll get more into the kinetics of that further down. We present a lot of the McMartin data. So your expected clinical course is really going to be early CNS depression, likely with an elevated osmolar gap, followed by metabolic acidosis with an elevated anion gap, the progression of GI symptoms, followed by renal failure, and then the final common pathway, like most tox exposures, of seizure, coma, death with some acidosis probably thrown in there. So the other cases that I've been exposed to and that you'll read about and that you'll see in text, you'll have the SPY calls you and says, I have a call from a doc and they have a mechanic who had some, a large amount of antifreeze on their skin, but didn't ingest any when they were working on a radiator in a car, or somebody was using appropriate PEE, but was spraying de-icer on a plane and could smell the de-icer and has no symptoms. There is a little bit of absorption through intact skin. There's really not a whole lot of inhalation absorption. The way that you're going to see significant toxicity from ethylene glycol exposure is from ingestion. And we can contrast that a little bit with methanol, which we're about to start talking about, where you can see significant toxicity from that inhalation route. So just be aware, you're going to see these questions in the poison control and occupational health setting, and you should realize that it's less of a hazard when it's not in the setting of ingestion. So for methanol, very simple structure, right? Should be easy to identify. Hopefully that'll be the one you get on the board exam. Windshield wiper fluid will be the big one. Again, like I said before, you will see these in antifreeze as well. Paint thinner, quote unquote bootleg alcohol, moonshining, one of the first alcohols off the column based on its boiling point and the vapor point relative to ethanol and the other alcohols is methanol, right? And you read about the hillbilly moonshiner going blind. Solid cooking fuel with the brand name being Sterno, right? The little cans of that gelled fuel you'd put under a chafing dish also have a high concentration of methanol. The toxicity is mediated by a metabolism to formic acid or formate via that same enzymatic pathway. So alcohol dehydrogenase and aldehyde dehydrogenase. And you're going to see weakness, headaches, CNS effects, metabolic acidosis. It does cause visual toxicity and eventually death. And again, you'll see that lethal dose reported as about 1 milliliter per kilogram. Again, take that with a grain of salt, right? Because concentrations vary and rat studies do not necessarily correlate well with our experience with humans. So there's another pathway of methanol metabolism. And again, you can see alcohol dehydrogenase at that slow metabolic step presenting itself as a target for intervention. And then you can see the subsequent formation of formic acid and formate. And then at the end of that pathway, you can see why we use folate to treat these patients as well as an adjunct, because it does kind of drive the metabolism towards just the formation of CO2 and water. What you can also see on this pathway, one of the things we talked about before, in alcoholics, they have a flipped NAD/NADH ratio due to their usually chronic malnutrition and then the chronic consumption of alcohol, and that has implications for how fast they're going to metabolize methanol to formaldehyde and formic acid, and also is going to make them form lactate and ketone bodies at lower doses of concomitant ethanol use, so that can exacerbate acidosis. So one of the takeaways from this is to be aware that these people can develop significant acidosis even in the absence of, even in the presence of concomitant ethanol ingestion. And then also that we can use either folinic acid or folate as an adjunctive treatment. And additionally, I kind of threw in this other thing here. They kind of have a third hit on the formation of acidosis, is because formic acid is a true mitochondrial toxin. It does inhibit cytochrome oxidase, right, like some of the other mitochondrial toxins we learn about. So metabolic acidosis through that route as well. And so you see the other way we're having metabolic acidosis is through the formation of formic acid and formate. So early methanol poisoning, right? This looks a lot like early ethanol poisoning and early ethylene glycol poisoning, as well as early isopropyl poisoning, right? So they all cause inebriation. You're going to see drowsiness. You're going to see an elevated osmolar gap. What you're going to see in a delayed presentation, right, is as they start to metabolize this methanol, they're going to develop weakness and progressive CNS effects, visual disturbance up to and including blindness, severe metabolic acidosis. The long-term effects, optic neuropathy, Parkinsonism, polyneuropathy, toxic encephalopathy. Some of these are mediated by the fact that methanol, right, is one of the basal ganglia toxins that we learn about. You can see there are some kind of characteristic MRI findings, optic nerve enhancement. We talk about that basal ganglia necrosis, especially the caudate and putamen. Putamen hemorrhage is kind of a characteristic finding. I don't know that it's described enough to be a board exam question. I do know that a lot of these people, after their, you should recommend to the primary team to obtain that MRI as they're kind of coming out of their toxicity and you're getting out of that treatment with fomepizole phase, that sedation and intubation phase. You want to get an MRI to make sure that they're not just experiencing ICU delirium and that they're not going to have long-term effects from their methanol exposure. Methanol huffers, right? So people huff methanol. This, you can kind of think about this in contrast to ethylene glycol, which we said doesn't have a lot of toxicity with inhalational exposure. Methanol, especially as a carburetor cleaner, is available in a form that's easy to huff. Paint thinner, right? We see a lot of huffers that huff paint thinner, which can have high concentrations of methanol. And what you'll see in some of these patients is that they can have high methanol and formate concentrations. Usually, though, despite their high levels, they don't usually require ADH blockade or hemodialysis. The degree of toxicity is disproportionately mild relative to serum levels, and there's a couple of good papers, one of them out of Colorado, that discusses this that you should look up. Isopropanol, so this is kind of the stepchild of our toxic alcohols. This is the one that we have a harder time getting excited about. It's clear, it's colorless, it's volatile, much like ethanol. Rubbing alcohol is a 70% solution of isopropanol. You have, and if you haven't already, you will get consulted for what people think are isopropyl ingestions when patients are ingesting hand sanitizer, either at home or in the hospital. And some of the consultations are good. It's like, hey, what do I do with this rubbing alcohol ingestion? And hey, you maybe want to check an ethanol level because most hand sanitizer now is just denatured ethanol, right? So that's most of the exposures you're going to see from hand sanitizer or ethanol, not isopropyl. There probably is some isopropyl around 5%, but that pales in comparison to the amount of ethanol that's in hand sanitizer. Isopropanol is metabolized to acetone, right? So a ketone, you don't feel great when you have that on board. You're definitely going to have an increased osmolar gap, but it shouldn't cause an anion gap metabolic acidosis. That's not to say that these patients can't have an anion gap metabolic acidosis secondary to their flipped NAD/NADH ratio from chronic alcohol use and increased lactate formation, decreased lactate breakdown. The old adage for isopropanol is twice or thrice is drunk for twice or thrice is long. So prolonged and more profound intoxication relative to ethanol. There's depending on the type of assay your institution uses for creatinine, you can have a false elevation of creatinine. It's something to be aware of. It shouldn't really have clinical consequences, but this can be how an isopropanol ends up getting dialyzed before having involvement with a toxicology expert. You should be aware that there's significant GI effects, much like alcohol. In high doses, it can cause a hemorrhagic gastritis. Isopropanol is definitely known to cause a hemorrhagic gastritis. The incidence reported, if you dig back through studies, we've had years where there's been isopropanol exposures as high as 30,000 in the 90s, with 3 or 4 fatalities reported. A lot of those had co-ingestions. It appears that number is decreasing, and that may be due to the fact that we're using a lot more ethanol rather than isopropanol in hand sanitizer. So isopropanol, this is kind of our progression of symptoms, and it looks a little bit similar to the other ones, especially maybe with a little more gastritis early on. It does have a pretty decent half-life, and that's probably where that adage of twice or thrice is drunk for twice or thrice as long is reported. That reported lethal dose, again, take that with the grain of salt. Lethality is much like ethanol, not common with good supportive care without significant co-ingestants. So diethylene glycol is the last toxic alcohol that we're going to talk about in detail. Diethylene glycol does cause inebriation, does cause polyuria early on. That may be an osmotic diuresis, also polypnea. This is followed by the progression of renal injury and then oliguric or anuric renal failure. Also progressive neurologic dysfunction, especially cranial nerve 7, but other cranial nerves can be involved. And then, much like our other alcohols, the final common pathway of coma and death. There's really kind of 2 classic presentations of diethylene glycol, one being an ingestion of brake fluid or another industrial fluid that contains a high concentration of diethylene glycol. And the other one is epidemics in the developing world, especially. This diethylene glycol is cheaper than propylene glycol and some other diluents that are commonly used in medications. So it can be used inappropriately as a substitute for those safe diluents to save money and maximize profits, especially in oral elixirs. So what you'll see is a rash of contaminated acetaminophen or a cold preparation or something like that, resulting in a lot of cases of diethylene glycol toxicity. And the first several cases, right, much like any epidemic, are not going to be caught early on. And then as we kind of realize what's going on, we can initiate treatment more soon, and the toxicity is usually less severe further on. In terms of our metabolism of diethylene glycol, you can see that the structure is a little more complicated, but the pathways are very similar. You can see those toxic metabolites, the 2-hydroxy-ethoxyacetic acid and the glyoxylic acid, are probably our main culprits for toxicity, with the 2-HEAA and the diglycolic acid probably both causing some degree of renal injury, but we'll get more into the discussion of toxicity, the toxic metabolites. And then there's also formation of that oxalic acid a point to be aware of is that this isn't just, a diethylene glycol molecule being metabolized to two molecules of ethylene glycol and then going down the same pathway. So that comes from rat models saying that there just isn't significant metabolism to ethylene glycol and then those toxic metabolites of ethylene glycol. And so this has kind of been rejected as the mechanism of toxicity kind of pretty early on, even before we really realized what the culprit compounds were. So the diglycolic acid is nephrotoxic and hepatotoxic. The 2-HEAA is more neurotoxic. You're a little less likely to present with an osmolar gap with diethylene glycol. And the thought here is maybe delayed presentation. A lot of this data with the lower incidence of osmolar gap is not from acute ingestions of brake fluid, but rather from outbreaks in the developing world with contaminated products. So that may be the reason for this lower incidence of osmolar gap in these presentations. So the phases early on, neurologic and GI symptoms with diuresis and polypnea, followed by severe acute renal failure and hepatotoxicity, followed by the development of significant cranial nerve and other neurologic dysfunction. And the keys to management: one, early ADH blockade and hemodialysis, much like with our other toxic alcohol exposures, and also early recognition of epidemic poisoning. And this is also pretty true for methanol as well as diethylene glycol. When you see methanol used as a cheap alcohol, or you see it accidentally produced and bottled with kind of home problems. So it's important to recognize epidemics of anti-GAP acidosis with neurologic and renal dysfunction as a potential toxic alcohol outbreak. So we're going to talk a little bit about some analytical issues. This is the classic graph, right, that we probably always draw on a whiteboard when we're teaching to other medical professionals about toxic alcohol exposure and metabolism, with the classic presentation being somebody presents with an elevated osmolar gap from the parent toxic alcohol, followed by a progressive decrease in that osmolar gap as it's metabolized, followed by a subsequent increase in the anion gap as those toxic organic acids are produced, with the kind of quote unquote normal patient being down there at the bottom with normal gaps with no exposure. So there's some diagnostic difficulty here. These are generic presentations, right? A lot of people present, especially in the emergency departments, with inebriation. And if you draw lab assays on our ethanol inebriated patients, many of them have elevated osmolar gaps. Many of them have elevated anion gaps. Many of them have renal dysfunction. Many of them have visual disturbance, right? So it can be very difficult to diagnose this clinically. History, like in much of toxicology, especially with intentional self-harm ingestions or in the inebriated patient, is frequently inaccurate. There's not necessarily a one-to-one correlation between the concentration of the various toxic alcohols and the severity of ingestion, particularly if they've co-ingested ethanol. Many patients can be relatively asymptomatic at presentation or symptomatically similar to their chronic ethanol use presentation. And then many places don't have a readily available toxic alcohol concentration, which is, kind of what we use to guide a lot of our management. So that can complicate management, and this can all lead to delays in treatment. So, my recommendation for this is to get a good history, if you can, from the patient, but if not from the patient, a friend, a family member, EMS, the police, anybody on scene who can let us know if there was packaging of potential toxic alcohol. Recognizing that these patients, when they're going to present with a toxic alcohol ingestion, are going to be confused, distressed. A lot of times they're comatose, and the delay between when they were exposed or ingested a toxic alcohol to the time they reported to the healthcare facility is going to limit our history. It's going to make us have to kind of make some assumptions and make some decisions without all the data points. So treatment. In terms of GI decontamination, right, there's a limited utility to activated charcoal. This is a liquid. People frequently are delaying and are delayed in their presentation, as I discussed on the last slide. If you have a known early presentation after a large ingestion, there probably is some utility to orogastric lavage with the recognition that you're probably going to need to protect their airway before you do that. Our treatment objectives are, as we said at the top of the lecture, to prevent the formation of toxic metabolites, right? Those toxic organic acids. Hemodialysis as necessary, particularly with methanol, and we'll discuss why. We want to remove that parent alcohol. We want to remove toxic metabolites. And then really we want to correct acidosis and electrolyte abnormalities that are likely to occur. So alcohol dehydrogenase, which is our target for our antidote, is an oxidative enzyme. It's concentrated in the liver, and this is that rate-limiting step in metabolism, is that metabolism of the alcohol to the aldehyde. So blocking this slow step is going to prevent the downstream formation of toxic metabolites. In terms of lactic acidosis, we know it's going to be disproportionately elevated, especially in ethylene glycol ingestion. We've talked about the flipped NADH-NAD ratio. We've talked about its relation to AKA. We've talked about not so much that you can have false positive elevations in lactates from other metabolites that are seen on the analyzer as lactate. And then propylene glycol ingestion can also present with a falsely elevated lactate. And the reason I just put this here is it can make it a little more difficult to trend out a lactate in this patient, especially once they're up in the ICU. And one of the things you'll get called back about is the improving patient whose acidosis is improving, who may be even improving clinically, who isn't developing significant visual or renal failure, but doesn't appear to have an appropriately decreasing lactate. And it's kind of appropriate to reassure the rest of the care team and the patient. So if you can't get a level, I would say still try to sit it out if it's going to come back for days, because these patients are going to have a prolonged course, and it is going to have some utility getting that level back. It's going to help guide our therapy, but we're not going to delay therapy waiting for a level if we have a suspicion or a history of ingestion. Serial bicarbonate measurements, those are an acceptable surrogate because we know if somebody is metabolizing these toxic alcohols, they should be developing organic acids and a metabolic acidosis. The other thing that we're going to do is begin tracking all this after their ethanol is 0. We don't want to be falsely reassured in a patient who has an elevated ethanol level, who's therefore kind of already occupying their alcohol dehydrogenase and limiting their formation of organic acids from the toxic alcohols. So if you're trying to look and give a practical recommendation for how often to check the bicarbonate, what you'll see written down is Q2 to 4 hours every 8 hours. You can imagine how difficult that might be to actually turn around in a busy emergency department. For methanol and diethylene glycol, the recommendation would be 2 to 4 hours for 12 hours. And the reason we say that is because we know methanol and diethylene glycol hang around longer in the body. They have longer elimination half-lives with or without antidotal treatment relative to ethylene glycol. So if you're receiving a call through poison, or if you're seeing someone at the bedside and you don't have access to a methanol or ethylene glycol or diethylene glycol level, this is a reasonable serial measurement you can undertake to assess for the development of toxic metabolite. So ADH blockade, right? This is our goal of therapy, is to prevent that first oxidation of a toxic alcohol to the aldehyde and therefore get no toxic metabolite formation. A historical approach was, and as is still used depending on your resources, is the use of ethanol, right? It's a competitive substrate for alcohol dehydrogenase, right? It has a much higher affinity than ethylene glycol for alcohol dehydrogenase, and has a higher affinity for alcohol dehydrogenase than methanol as well. The traditional goal of therapy has been this serum ethanol of 100. And you can see that's because it protects against these high levels of metabolite. It would be reasonable, and we'll talk a little bit about some other recommendations, to try and reach a higher level depending on the level of methanol and ethylene glycol. Toxic alcohols are eliminated via renal, pulmonary, and extracorporeal routes. So we are going to go over some things too. We can increase the elimination by those routes. The challenges of ethanol therapy, rapid and erratic metabolism, right? You've probably sat in a lecture and probably the most commonly quoted number for ethanol metabolism that has data behind it is 9 to 27 milligrams per deciliter per hour. So that's a pretty wide range in terms of metabolism. With chronic inebriates probably metabolizing at or above that 27 milligram per deciliter number. But still a wide range. So it's difficult to maintain a serum concentration. It requires frequent lab monitoring. Alcohol itself, right, is a toxin, so it causes CNS depression, causes liver injury, requires ICU level care. It has a low acquisition cost, but a very high overall care cost. So, and also, as you all know, patients with a lot of alcohol on board tend to be disagreeable. The advantages of alcohol are as listed: low acquisition costs, readily available in almost any environment around the world, and then many routes of distribution: PO, IV, and as my colleague Dr. Babarda demonstrated, PR administration has been used to prevent toxicity from a toxic alcohol. So this is pulled from a McMartin study, and this table is just a simplified dosing suggestion for IV and oral ethanol treatment for toxic alcohols. And you can see it gives recommendation that's based on the concentration of your alcohol solution, whether it's oral or IV. And there's a little disclaimer on how they adapted them. And also what we'll do down at the bottom of these two parts of the table, you can see that there's an adjustment for the drinking dose or the infusion rate during hemodialysis as well. The alternative to ethanol is, of course, fomepizole. This structure is one of the ones that we all tend to memorize for the boards. 4-methylpyrazole. It's a competitive inhibitor of alcohol, more than 3,000 times the affinity of methanol. So you can see that's much higher than that 15.5 times affinity relative to ethanol. Indicated for ethylene glycol and methanol and probably diethylene glycol. It's been used in humans for a long time. The advantages: it's safe, it's easy to use, there's no reported CNS depression or intoxication, it's not hepatotoxic, you don't have to check serial blood alcohol levels, it's easy to dose, you don't have to receive this in the ICU. And then overall, the drug is probably a lot more expensive than obtaining ethanol off the shelf. The overall costs are probably a lot lower in terms of the total healthcare costs. In terms of head-to-head comparison, you're not going to find a bunch of high-quality prospective randomized controlled trials. You're going to see systematic reviews that have, a systematic review is only as good as the data that goes into it, and it's not great data going into these reviews. So there's not really a difference in mortality, ICU stay, or sequelae. There were fewer adverse events with fomepizole, but neither treatment had a lot of adverse events. So traditional fomepizole guidelines would say immediately upon your suspicion of ethylene glycol or methanol ingestion to go ahead and begin treating with fomepizole, or treat at these levels listed at 20 milligrams per deciliter, and then discontinue treatment when you had a level less than grams per deciliter. What we have available to us more recently is more experimental data and a lot of case reports. And so we can make some recommendations that are probably a little bit better reflection of actual clinical practice. The downside being that they're based on the availability of methanol and ethylene glycol levels, right? So you can see these recommended criteria. We don't have to read them word for word. Just know that there are some recommended treatment levels that are a little bit higher for ethylene glycol than methanol, and then suspected history with an elevated osmolar gap greater than 25. And then you can see some criteria down at the bottom, which basically say acidosis and osmolar gap. And then they give some other things that we can use in the absence of ethylene glycol or methanol levels, like the presence of urinary oxalate crystals or visual disturbance. We also have simplified dosing suggestions for fomepizole here. You can look these up in pretty much any standard reference. What I would say is you're gonna have to modify this dosing in hemodialysis, whether you're using CVVH or intermittent hemodialysis. You can see that we give that loading dose followed by a lower dose. And then for dose 5 onwards, we're going back to that loading dose with the idea that we're auto-inducing our own metabolism of fomepizole and probably experiencing more rapid metabolism as we have continued dosing. Um, we're not nephrologists, at least most of us are not. You're going to be managing a lot of these patients in conjunction with nephrology, and you need to be able to kind of speak coherently about how you should time this fomepizole dosing relative to dialysis. So these are recommendations that we use at the Minnesota Poison Control Center that are kind of based on manufacturers' data for cartridges and dialysis machines, as well as the package insert for fomepizole. And so, we don't have to go through this one word for word either, but you can pull up this slide and see how to provide recommendations for timing of your fomepizole dosing. So in other words, not just saying, hey, if I have an 8-hour dialysis run, we're going to give fomepizole twice, but also how we're going to time our fomepizole dosing relative to the begin and end of dialysis and the last dose of fomepizole. So a little more practical use there. In terms of when we're going to do hemodialysis, right? If we are experiencing renal failure, we're not going to clear those toxic metabolites as fast. So that's somebody that should probably receive hemodialysis. Significant and worsening metabolic acidosis. The measured ethylene glycol or methanol greater than 50, that one's a little more nebulous. The idea being that maybe just prolonged exposure of the brain to hyperosmolality is bad for it, and therefore we shouldn't just block the metabolism of ethylene glycol and methanol and then kind of bathe the brain in this parent alcohol, even though we're not forming toxic metabolites for an extended period. Because when we give fomepizole, we do know that we prolong the metabolism of ethylene glycol, and especially we prolong the metabolism of methanol, going from an 8-day elimination 8 hour out to 44 hours. And just also for hemodialysis, remember, we do have to adjust the dosing of ethanol and fomepizole, and a lot of that kinetic work has been done. And you can look up those papers or refer back to this PowerPoint and see how to adjust your dosing and timing of ethanol and fomepizole in the setting of intermittent hemodialysis or CVVH. In terms of some practical dialysis instructions, this is a table that we use at Minnesota Poison Control. And that asterisk is there. This is not necessarily, again, based on a randomized control trial. Rather, this is looking at just the hard math of, what your flow rate of dialysis is. And this table assumes a 300 milliliter per minute flow rate. It assumes a urea clearance of the cartridge of 250 mLs per minute. And this is for gross estimation of how long a dialysis run should be, and based on the patient's weight, which gives us their total body water, as well as the level of methanol that they have. And this equation down here at the bottom, and I've kind of listed out the variables for you, is how Dr. Orozco kind of came to this table. But this is really all based on manufacturer specifications of the machine and the cartridge. It's based on cases that have been treated through Minnesota Poison Control and published in the literature, as well as the expert opinion of nephrologists. So you're not going to find a standard reference backing up this table. But if you're having trouble deciding, or if somebody's asking you for a recommendation for how long to dialyze a toxic alcohol, this can provide you with kind of an idea of what that should be based on the level and the patient's weight. As I said before, the apparent half-lives of ethylene glycol and methanol, you have them up on the board here, and you can see that you're prolonging that half-life when you're blocking the metabolism, as you would expect. But the point I really want to make is that methanol especially has a prolonged half-life in this setting of fomepizole use. So you'd be really hard pressed to, at think if in an early presenter, especially, you're probably going to end up using a lot more dialysis for methanol than with ethylene glycol, even though we classically think of ethylene glycol presenting with severe renal injury. In terms of the adjuncts that we talked about, folate and methanol, right, we're shunting metabolism to those non-toxic byproducts. For ethylene glycol, pyridoxine, thiamine, magnesium, again, shunting metabolism to non-toxic byproducts. The other thing that I would just be aware of, it's, at least in my practice, it's been very rare to treat one of these that wasn't also a chronic user of alcohol. So some of these people are going to require thiamine and folate supplementation and magnesium supplementation at baseline anyway, potentially even high dose thiamine supplementation. So in terms of a management summary slide, I would say that if you start with kind of what we do for all of our tox patients, GI decontamination is not going to be super useful unless you're doing orogastric lavage and aspiration early on after a presentation. Activated charcoal isn't really going to have utility. We're going to check a blood alcohol level. We're going to check their chemistry to check their renal function and their acid-base status especially. We're going to get a serum osm level. We're going to check their calcium. We're going to check their lactate. And those things are going to allow us to calculate their anion gap and their osmolar gap. I throw in what we call our suicidal ideation panel. My most recent dialyzed and treated with fomepizole methanol patient also had an acetaminophen of 532 micrograms per ml. So you want to remember your other things as well. And then a urinalysis with micro, fluorescing the urine with the Woods lamp is an old school thing that's been proven not to be very sensitive or specific, but the presence of calcium oxalate crystals can kind of clue you in that you're forming some toxic metabolite and need to treat for ethylene glycol toxicity. The concentration of a toxic alcohol, which is usually a send out, I would urge you, if your facility, like the places where I work, has the ability to courier over a specimen and get that 1 hour turnaround with another hour or so of transport, it's really gonna help you out. And I would make sure that your facility has the ability to do that. And then in the absence of a toxic alcohol level, serial bicarbonate with serial anion gap and osmolar gap calculations is going to be useful. In terms of our management summary, alcohol hydrogenate. Fomepizole is preferred. Ethanol is okay. We have good guidelines. We have coherent records we can give people to use ethanol treatment, especially in more austere or less resource-intense environments. For ethylene glycol, we're going to supplement with thiamine and magnesium and pyridoxine, and I have the dosing regimens there. For methanol, we're going to supplement with folate, and then we're going to do hemodialysis as indicated. We're going to adjust our fomepizole dosing as indicated or our ethanol dosing as indicated. And we know that we have coherent recommendations for those based on weight and concentration of toxic alcohol. And our last overall summary slide to kind of bring it all back, toxic alcohols are metabolized via the alcohol dehydrogenase pathway to organic acids, which are toxic metabolites, and exert most of the toxicity rather than the parent compound. The final pathway being acidosis and end organ damage, with those end organs being for ethylene glycol, particularly the kidneys, for methanol, particularly the brain and eyes, and for diethylene glycol being the brain, cranial nerves, and kidneys. In the absence of toxic alcohol level, careful observation of anion and osmolar gaps and acidosis can be used as a surrogate, because we know that we should progress from the presence of those osmotically active parent compounds to this presence of those toxic metabolites that cause an increased anion gap acidosis and decrease the bicarb. The mainstay of our therapy is, of course, alcohol dehydrogenase blockade. Hemodialysis may be required, and you need to be prepared to speak coherently on it and give appropriate recommendations and have that discussion with nephrology and internal medicine, intensivist, pediatrics, and all those specialists that are going to be involved. So I have 2 pages of references here. I really recommend, the McMartin paper at the top is a good place to start when you're talking about the reasons why we do what we do in terms of dialysis and fomepizole and ethanol. That's a really good primer. But all of these references were used in the creation of this talk. So I thank you. If you read this talk and you have any questions, you can always email me.